pleasure then to introduce tonight's host and moderator, Dr. Samuel Lau. Dr. Lau is Professor Emeritus at the University of Florida College of Dentistry, sorry Sam, an advisor member of the McGuire Institute, and he is the past president, or a past president, of the American Academy of Periodontology. He's a current officer of the Academy of Laser Dentistry, and Dr. Lau provides periodontists, dentists, and dental hygienists with the tools for successfully managing the periodontal patient. He was selected Dentist of the Year by the Florida Dental Association, is a distinguished alumnus of the University of Texas Dental School, and has been awarded the Gordon Christensen Lecturer Recognition Award. He is also a past president of the Florida Dental Association and a past ADA trustee. It's my pleasure to introduce tonight's host and moderator, Dr. Samuel Lau.
Well, thank you, David. And we really appreciate you taking out some time to be with us this evening for this thing was entitled Landmark, and we do believe within the next few minutes we're going to demonstrate to you just why we believe this study is so critical to what we do in the present and in the future in managing periodontitis. We have an illustrious group to be with you tonight, and what I thought I would do is just introduce all of them at one time, and actually in sequence of how they're going to present, and then we will move forward. Our first presenter will be Dr. Rick Hurd. Rick is from Victoria, Texas. He's actually the executive director of the McGuire Institute. He practices periodontics. He's boarded. He's done many presentations in the area of periodontics. And he will actually speak to us about the design of the study, which I think you're going to find to be very important. As you and I know, as we get into best evidence dentistry and meta-analysis and systematic analysis, the way a study is designed has a great deal to do with the results. Second on our agenda will be Dr. Don Clem. Don is a past president of the American Academy of Periodontology, also the foundation of the AAP, chairperson of the American Board. By the way, he just recently was awarded the 2020 Gold Medal Award. For those of you who are periodontists know that's just about the highest award the Academy gives. So congratulations to you, Don, for that. And Don actually was the PI of the study. Don practices in Fullerton, California. He's a perio graduate of San Antonio, University of Texas, and actually so is Rick. Next on the agenda, and Don will be talking about the results. And then for panelists, we're bringing in Dr. Paul Chang from McKinney, Texas. And Paul is very unique. Paul is one of the very few dual boarded both periodontists and prosthodontists in the United States. I think I could probably count on one hand just how many are out there. Paul also is a diplomat, and he also graduated from the University of Texas at San Antonio. And he will be to present actually translational his experience using Erbium Chromium YSGG technology and using the REPAIR program, and giving us a little bit of insight into really what the procedure is. Last on our agenda, but not least, is Dr. Stephen John. I'm not sure what's wrong with Dr. John. He didn't graduate from San Antonio, but he graduated from a great school, University of San Francisco, UOP for his grant, and actually he taught at University of Pacific. He is somewhat also unique too, and then after a few years decided to join his father, who was also a periodontist. And Steve practices in San Mateo, California, and he also has done significant number of presentations on the techniques that you're going to see. So I really welcome our four group, and as I also welcome all of you who are to be with us this evening. So to begin with, Rick, I would just like to turn it over to you and to begin talking to us about that critical aspect of the study protocol.
Thanks, Sam. I'd like to provide you all with the rationale for the study design. And then as Sam indicated, I'll be handing it over to Don Clem for a review of the results. Next slide, please. The McGuire Institute was approached by BioLace with the concept of conducting a definitive clinical investigation using their Erbium Laser, the Waterlace Express. We determined that the REPAIR protocol would most closely compare to other minimally invasive surgical techniques. Therefore, MIST was chosen as the control arm. The title of this investigations article that's now electronically available through the Journal of Periodontology is a comparison of erbium, chromium-doped, yttrium, scandium, gallium, and garnet laser to minimally invasive surgical technique in the treatment of interbony defects, 6-month results of a multi-center randomized controlled study. And that's open access for anybody that wants to search it through the JOP online website. The main study objective was to compare efficacy and patient-reported outcomes of the test therapy and control therapy. The study design for this randomized controlled clinical trial was for a non-inferiority comparison of test therapy REPAIR to the control therapy MIST. Next slide, please. To provide some background on what guided us through our study design, we reviewed the literature as it related to lasers in the treatment of periodontitis in general, and specifically the express laser's wavelength. For a nice illustration of the shortcomings of most laser-based studies, you can all look no further than the AAP's Best Evidence Consensus on the use of lasers alone or as an adjunct to non-surgical and surgical treatment of periodontitis. These recommendations, based on the best evidence available, were being formulated in 2017. At the same time, we were developing the protocol for our study on REPAIR versus MIST. The BEC noted the following concerns about the existing body of evidence. Number one, it's lacking, which results in a low level of certainty due to the limited number of well-designed studies. There's a lack of standardized and calibrated protocols for procedures, leading to a lack of consistency with respect to machine settings and use of the laser. The long-term data on this topic is also lacking, and the diversity of wavelengths in general makes it challenging to analyze the overall scope of the topic, evaluating the use of lasers in the treatment of periodontal disease. They also recommend that laser therapy needs to be compared against appropriate controls, including minimally invasive and regenerative treatments in adequately sized randomized controlled trials. Next slide, please. So with the BEC recommendations in mind, I'd like to quickly review the study design we developed. The following inclusion criteria were chosen. We were selecting subjects who were diagnosed with periodontitis stage 3 that were aged 18 to 75 years. They could be enrolled. Subjects must have at least one qualifying study tooth with probing depths greater than or equal to 6 millimeters. And most importantly, this still had to be present. This probing depth still had to be present 4 to 6 weeks following scaling and root planing. Next slide. They would also need radiographic evidence of an interbony defect greater than or equal to 3 millimeters in depth and a defect angle greater than or equal to 25 degrees. If subjects had more than one qualifying defect, they could not be on adjacent teeth. Next slide. The following exclusion criteria were used, such as the inability to identify a CEJ or landmark for probing measurements, the presence of an acute periodontal abscess at the time of MIST or REPAIR therapy, subjects with unaddressed traumatic occlusion of the study teeth and mobility greater than 1 that persisted by the time we were employing MIST or REPAIR care. We excluded third molars, defects distal to terminal second molars, and endodontically treated teeth. Subjects with systemic diseases that would complicate wound healing that were uncontrolled were also eliminated. Next slide. Subjects that were heavy smokers or heavy users of alternative forms of tobacco were eliminated, and subjects taking the following medications 30 days prior to day 1 of the study or during the trial, such as systemic antibiotics, various forms of corticosteroids, immunosuppressants, calcium channel blockers, and phenytoin. Next slide. Upon being enrolled in the study, treatment included scaling and root planing of study pockets and any other teeth with probing depths of 5 millimeters or greater. 4 to 6 weeks after scaling and root planing, subjects were randomized to either the test therapy repair or the control therapy missed. The subjects still had to exhibit a minimum 6 millimeter probing depth following the scaling and root planing, and periodontal maintenance therapy was accomplished every 3 months with no probing for the first 6 months. All clinical assessments were accomplished by a blinded examiner over that 12-month period. With respect to the repair protocol and the BEC concerns regarding a lack of standardized protocols, this treatment sequence is standardized by the very nature of the repair menu and the machine itself. As you can see from this image taken from the Waterlace Express control screen on the right-hand side, the treatment steps for the repair protocol are listed around the menu wheel. The only step we did not follow was the gingivectomy, as the control therapy missed does not include a gingivectomy. Next slide. With selection of each of the 6 procedure steps, the surgeon is instructed on which tip to use, and the program adjusts the settings for the laser accordingly. The repair procedure starts with the removal of the outer pocket epithelium from the pregingival margin to 1 millimeter coronal to the mucogingival junction. Then the pocket epithelium is removed, allowing for reflection of a mini flap. Next, scaling and root planing without the laser is provided. The laser is then used to debride the root surface and the defect. This is followed by bone decortication at the base of the defect, and a final sulcular debridement is accomplished that also induces coagulation. The only factor not controlled in the duration of each step as it is done to completion. In other words, you don't move on to the next step until that part is complete, just as you would perform any step of a conventional surgical procedure. For comparison between treatment arms, we did record the time required for the total procedure of each treatment modality. Next step. The control arm was the minimally invasive surgical technique, otherwise known as MIST, that was been described by Cordellini. Following the tenets of this approach, a papilla preservation incision is accomplished on the buccal aspect, followed by intrasulcular incisions to the line angles of the defect-associated teeth. Flap reflection is minimal on the buccal and lingual surfaces to expose at most 1 to 2 millimeters of the alveolar crest. And the site is then debrided along with scaling and root planing, followed by closure using a modified internal mattress suture. Next slide. If the defect was found to extend beyond the proximal side of the study tooth, we strove to maintain the concept of minimally invasive access to treat the defect that was encountered. These principles were adhered to via minimal extension of the flap in the direction the defect was found to continue on the study tooth. We did not perform the modified MIST approach, as a flap was reflected on both the buccal and lingual aspects. And next slide. The following outcome measures were assessed as part of the study. We evaluated safety in terms of treatment-related adverse events and subject-reported tolerability. In terms of efficacy, the primary outcome variable assessed was gain in clinical attachment levels. Secondary efficacy measures included recession, probing depth reduction, bleeding on probing, and at 12 months, we're going to assess radiographic measures of bone fill in millimeters, as well as % of defect fill. Other outcome measures included, next slide, tooth mobility, treatment time between repair and MIST therapies, and patient-reported outcomes for pain, anxiety, and satisfaction via a home diary that was used daily for the first week, and in-office questionnaires that were taken out to 1 year. Next slide. For this study, we used 6 of the McGuire Institute, or IMAC, investigators at 5 locations, with the principal investigator being Don Clem in Fullerton, Mike McGuire and Todd Shire in Houston, Chris Richardson in Richmond, Greg Toback in London, and myself in Victoria. The prior laser use experience amongst these investigators in this treatment modality ranged from no experience out to 15 years. Next slide. So I hope this aspect of the presentation illustrates how we strove to provide a study that addresses the shortcomings found in the existing body of evidence, and how it also aligned quite nicely with the recommendations from the AAP's BEC on the use of lasers in the treatment of periodontal disease. So now I'm going to turn it over to Don Clem, again, our study principal investigator, for a review of the results and take-home messages. Thank you.
Thanks, Rick. Let's go ahead and pull up the first slide. So when we look at our 6-month results, it should be noted that we had 54 subjects enrolled, of which 53 completed the study at 6 months. We had a pretty even distribution of males and females, and our minimally invasive surgery arm, there were 26 subjects, and in the Erbium Laser arm, there were 27 subjects. And you can see that we had a fairly even distribution of moderate smokers. Those smoked less than 10 cigarettes per day. And even our average baseline probing depth was about 7 millimeters. I'd also like to point out to you that many of these subjects, in fact, 36 of the 54 subjects enrolled came from periodontal maintenance patients. These are individuals that had been treated, had been in maintenance for some time, and had residual defects. And that's going to be one of the take-home messages that we're going to talk about after we review the rest of the results. Go to the next slide, please. So in our clinical outcomes, remember that we tracked both recessions, probing depth reduction, and clinical attachment levels. This is significant in laser studies because many of the studies that we've reviewed in our literature review and our design looked at strictly probing depth reduction, or they looked at applying laser therapy without any prior root planing. To us, this was problematic for the following reasons. If you only track probing depth reduction without tracking clinical attachment levels, you could actually lose attachment with the treatment arm and have a decrease in probing depth reduction. And therefore, if you only report probing depth reduction without looking at clinical attachment levels, your cases could actually be losing attachment, and yet you would still report a positive outcome of probing depth reduction. Secondly, we were in tune with making sure that before these patients went to treatment, before these patients went to surgery, either with either with Erbium Laser or with minimally invasive surgery, that they were root planing prior to treatment. Remember that in our inclusion criteria, they had to have 6 or greater millimeter of probing depth to qualify for the study. Then after the root planing in initial therapy was completed, they had to maintain at least a 6 millimeter probing depth to move on to surgery. So 36 of the 54 subjects and 57 of the 80 defects had a history of prior periodontal therapy and ongoing maintenance care. Traditionally, those treated patients are the most difficult to see significant results on with any therapy. Next slide, please. So with our clinical outcomes following surgical therapy, in terms of probing depth reductions, we had a 1.63 millimeter probing depth reduction with MIST versus a 1.71 millimeter probing depth reduction with Erbium lasers on the mean. Clinical attachment level gains, we showed clinical attachment level gains in both the control and the Erbium laser treatment. You can see on the right that there is an illustration in our Erbium group. A was our pre-treatment probing depth, with B, our 3-month and 6-month radiograph, our 3-month results and our 6-month radiograph. With our control group, starting in figure D with MIST, we have a demonstration of our pre-surgical probing depth and our post, approximately 4 millimeters at 6-month post-surgery, and the 6-month radiograph. We found that there were no significant differences between the groups, including multi and single rooted teeth, gingival inflammation, bleeding on probing, and mobility. And the Erbium was found to be non-inferior to MIST. Now, non-inferior trials are becoming more and more popular. And the reason is that in order to find a superior treatment, we usually talk about non-significant differences. But if you can show a non-significant or even a significant difference, just because two groups have a significant statistical difference doesn't mean that they have a clinical significance. So with a non-inferior test, what we're really being able to show is that we are no worse than missed. In other words, we are just as good as minimally invasive surgical therapy. What that means for the clinician is this. It allows for a non-inferior test, it allows that a clinician can recommend the treatment without fear of loss of clinical effectiveness. This has a range of implications, particularly when you're treating large populations of periodontal patients. We know that periodontitis is a chronic disease. We know that as patients move through a maintenance service after many years, that some of these patients have recurrence of disease, some of these patients have persistent defects, and we really have limited, up until now, limited options in managing those patients, where in effect, patients desire minimally invasive therapeutic options and minimally invasive revisions of these residual defects. We also know that this really paves the way for future research in terms of how does the repair protocol and the Erbium laser function, not only without regenerative materials, but perhaps how would this now be results in terms of managing these cases with additional regenerative and biologics. This, we believe, sets the standard for future laser research, which has not been done in the industry. Most of the laser research is either case reports, poorly done randomly controlled trials, non-controlled trials, non-blinded studies. In this particular study, we're really planting a flag in the ground and saying to the laser industry, we as clinicians need best evidence with which to provide the best advice and most benefit to our patients that we treat. And that's what I think is the major take-home message of this study, is that this now paves the way for other industry leaders to duplicate this study and add on the initial randomly controlled trials that we've completed. So with that, we'll move on, Sam. One of the other aspects that this study has shown us, particularly in a non-inferior trial, we not only look at the clinical results in terms of clinical measures, we look at other ancillary results. And in this study, we looked at PROs, patient-reported outcomes. Those patient-reported outcomes are centered around a couple of different factors. For example, we were able to show that we had shorter procedure times using the Erbium approach as opposed to MIS. In fact, 5 of our 6 centers reported less procedure time per defect using the Erbium approach rather than the traditional MIS. Next slide. In terms of patient-reported outcomes, if you look at the FDA in terms of how they look at both medical devices and pharmaceuticals, they are requiring now a study including patient-reported outcomes. This is a separate analysis, separate from our group. It's more than just a patient diary. Patients would fill out surveys that were conducted by non-clinical staff. That's important because if you're the treating doc or if you're the treating surgical assistant and you ask a patient how they've done in their post-operative course, they want you to be proud of them. They want to give you a positive result. So we tried to eliminate any form of bias, and the PROs and patient-reported outcomes were analyzed separately. It was actually pretty striking that these differences persisted in terms of the Erbium outcome, and the Erbium experience was clearly superior to the MIS groups. Next slide. So with that, I'd like to thank you for your attention. I hope that we have a future plethora of new evidence in this vein with these types of designs. And Sam, I'll turn it back over to you.
Thanks, Don. And so now I would like to introduce again Paul Chang. And so Paul, give us some, some of what your experiences have been, why you chose erbium over any other wavelength, and what does that mean to the practicing periodontist, dentist, and hygienist out there?
Sure. Thank you, Dr. Lau. Hello, everyone. There are a couple of points that I want to highlight from this study. As previous presenter have mentioned, the Erbium Laser protocol performed equally well in the clinical pocket reduction compared to the control protocol, but with less postoperative discomfort. Compared to the control protocol, laser therapy took less chair time and is not as difficult to learn. One thing to note is that there are 6 operators from this study. Their laser experience varied from 0 to 15 years. Yet they were able to produce the same clinical outcome and spent shorter treatment time compared to the control technique. I am the least experienced laser user in this panel. I can tell you, yes, there is a slight learning curve, but it is not difficult to get started, especially with the way BioLase has set up their laser. There's no need to memorize the power, the pulse rate, air-water mix settings for each step. It uses a graphic touchscreen that has all the clinical steps pre-programmed in there. When you press the button for each step, it will prompt you for the tip that you need to use and automatically adjust the rest of the settings for you. Next. So before I get into the clinical implications, I would like to spend a brief minute to discuss lasers in general, because they're not the same. But many of my colleagues have told me, laser's a laser. I'm just going to get one for the marketing purpose so that I can tell my patient that, yes, I have a laser in my office. The 3 laser systems that's useful in a perio office are diode, ND, and erbium. Both diode and ND laser energy is highly absorbed in melanin and hemoglobin. When performing soft tissue incisions, the tissue is cut by the thermal energy generated from the laser. Think of it as an electrosurge. Erbium laser works differently from both of them. Erbium laser is highly absorbed by water and hydroxyapatite. It ablates both hard and soft tissue by heating up water and cause it to explode, thus separating the tissue at a cellular level. Because of this, there's less thermal damage to adjacent tissue compared to the other lasers. Next. Both diode and ND lasers are not well absorbed by water nor hydroxyapatite. When they're used on root and bone, laser energy is transformed into heat, which increases the surface temperature and can cause thermal damage, as you can see from these videos. That's why I believe erbium laser is the best laser for a perio practice. Think of erbium laser as your 15C, electrosurge, piezo, and high-speed handpiece combined into one. Next, please. From this study, you know laser can be an important adjunct tool to increase perio treatment success. Some of you may say, well, periodontal treatment is only a small fraction of my practice nowadays. How can I justify purchasing such an expensive laser? Well, let's see how can we apply some of the same principles from this laser perio protocol to other procedures in a perio office. Next. Well, the first step in laser perio protocol is removal of outer and inner pocket epithelium. We do this to slow down the apical migration of epithelium, which prevents the formation of bone, connective tissue attachment after periodontal surgery. Next, which other procedures do we need to remove the gingival epithelium? How about soft tissue grafting procedures? Instead of trying to remove the outer epithelium of the papilla using a blade or scissors, you can use laser to remove it in a more precise and controlled manner. Don't you hate it when you cut off too much papilla and there's almost nothing left to suture the flap to? Next, how about extraction sockets and immediate implant sites? Don't we want to remove the gingival epithelium as well in these procedures to help with bone regeneration and osseointegration? Next, I said earlier, nothing works better than a laser in cleaning periodontal defect. The tip comes in a variety of length and can be as thin as a mechanical pencil. How else would you reach to the bottom of this perio defect to remove granulation tissue, detoxify the bone, and root without removing excess healthy bone? When you have a narrow furcation defect, most of the times hand instruments is useless. Laser can be an important adjunct in making sure that we remove as much granulation tissue and calculus as possible out of the furcation to promote regeneration. Next. What about soft tissue regeneration? Studies have shown laser is effective in removing smear layer and opening the dental tubules. Nowadays, I combine EDTA with laser to ensure a better result. Who hasn't seen failing an alien implant these days? Well, Erbium Laser is the only laser that can safely remove granulation tissue and detoxify around an implant without changing its surface characteristics. What about decortication step? The decortication step allows progenitor cells to easily access to the grafting material and to facilitate prompt angiogenesis. It also enhances the physical connection between the bone graft and recipient site. Where else can we apply this step? What about implant repair? Next. How about lateral ridge augmentation? With Erbium Laser, back please. With Erbium Laser, I can make my decortication a lot more precise. By using a 12 to 14 millimeter long tip, I can reach to areas where it is impossible for a handpiece to do. So let's ensure a good physical connection between the bone graft and the recipient site. Next. There are a lot more clinical applications to talk about. Given the time constraint, I will not be able to go into them into details. As we begin to understand the characteristics of the laser more, the role of laser in periodontal and perio implant surgeries will expand rapidly in the future. I'm very excited to be part of it. Thank you.
Well, thank you, Paul. That was excellent. And now for our last presenter on our panel will be Steve and John. Steve?
How y'all doing? That was my Texas talk right there, y'all. Anyway, Sam, I had to put that in for you, okay? So kind of what I want to go over today is just to kind of go over a few things about my personal practice and why I kind of started to do that. I have a couple of videos I actually want to end up showing you guys. Next, please. So the first question people end up asking me is, why did I get involved with lasers in the first place? So honestly, it had to do with probably why a lot of you people are here tonight, of how are lasers going to help me. So we kind of look at the idea of how do we want to get our practice growing? How do we want to make ourselves different? How do we start to do some more improvement of our practices? So part of the idea of trying to figure out how to make it different is the idea of looking into laser therapy. One of the things about once I got involved with lasers, started looking at the different types of lasers, just like Paul said, not all lasers are the same, you guys. And that's the reason why you happen to choose the water-laser laser, because it's an all-tissue laser. So when I finally got involved and decided to step into purchasing the laser, I started thinking about, what about the learning curve? Now, as most periodontists, I've been doing perio for now 35 years. So actually for the last 25 years, I was doing the exact same thing and I have perfected. The last thing I wanted to do is to put in a whole new technique and go through a learning curve and learn how to do it. So I was very reluctant about doing that. But once I purchased laser and took the training courses, I became a lot more familiar, comfortable with the procedure itself. Now, with that in mind, I brought the laser in practice and I thought, who am I going to start to do work on these patients? Just like Dr. Clem had said, you take our patients, as periodontists, we have most of our patients who are in our private practice, who they're either refractory patients, they're dental phobic patients, they're patients who have already had surgery before, but they're very reluctant to go ahead and step in the next phase or have surgery done again. So most of these patients I've established a good rapport to, and so they were kind of comfortable with me. And I said, hey, look, you guys, I've got a laser. We can do this procedure called repair. Let's give it a try and see how things go. And they trusted me. Most of my learning curve came down towards working on my maintenance patients. And from there, I happened to learn that number one is that this procedure actually did work. And number two, my patients accepted it very well. So I kind of find it ironic the fact that the McGuire study actually supported what I learned in private practice. All right, next slide, please. Let's see. All right. Sorry, this looks a bit different than I had before. So the so one of the things about private practice is that we have to kind of keep in mind that even though we're learning about repair, is that not every case is going to be a repair case. I kind of want to make sure that the periodontists understand. When we go through our training, when we go through our instructors, they'll teach us a little bit of a different type of a procedure. So it's kind of like, Sam always uses the analogy of just because you own a hammer doesn't mean that every periodontal treatment is a nail. What repair provides us is a type of therapy that we can add to our armamentarium of all these other different types of treatments and therapies that we can use for our patients. So please don't think that every single time I see a patient, we just do repair. While most of my patients, honestly, are repair patients and they respond well to repair, there may be times I kind of go off to the side or may do a variability of it. And so I kind of want you to kind of realize that not every treatment, not every patient is going to be a repair patient for periodontal treatment, but the majority of my patients actually are. What I have noticed is that I need water to keep my mouth wet. What I have noticed is actually that in my treatment, in my therapy, I almost pick up the laser with almost every treatment that I end up doing. And even though that I wasn't intended to do repair, even if I'm going to do, for instance, other types of therapies, I will pull up my laser. And the main reason why that I go ahead and take out the laser is I found that, number one, I have decreased bleeding, so therefore I have better visibility. And that's a key in optimum for treating our periodontal patients. I also found that there's far less post-op discomfort, far less complications, and I have found there's actually faster healing also. Next slide, please. All right. So one of the things about the McGuire study that we talked about is the whole idea of repair. I'm going to show you guys two videos. The first video is actually a 1-minute video of a 15-minute procedure, which kind of goes through the steps of repair so you kind of see what we're doing and what we're doing. And what I'm going to do is to kind of point out a few of the important things about the procedure itself. It's not meant to be a step-by-step learning process. It's kind of like what's your whistle, but so you understand what we're doing and why we're doing it and kind of see exactly what the different steps are. The second video is actually going to end up being actually a severe case I treated utilizing repair and truthfully even like a little bit of variation in repair. So you can kind of see how the treatment can be even in some of these severe cases. Next, please. So here is an actual case of start to finish, large defect on the mesial of that bicuspid. The first step is the deepithelialization, and you can see how we're kind of going across with the tip to do the deepithelialization. Then we want to remove the granulation tissue within the pocket. And you see that there's a little piece of calculus and materials coming out. Keep in mind, though, the laser doesn't always remove all the calculus. Again, some of you think that this is a non-flap procedure. It actually is a flap procedure. We are reflecting a mini flap. So don't think this is a flapless procedure. We actually do a flap reflection when we do that. If you can't see it, you can't treat it. So the key comes down towards is reflect as much as you need in order to go ahead and see the defect. We utilize ultrasonics and hand instrumentations to get into the defect. I usually try to minimize the amount of reflection of the papilla as much as possible, just so I preserve my papilla, I don't suffocate it. Again, hand cementation. We do decortication to establish bleeding in the pocket itself, do a little bit of pressure, soft tissue pressure. I like periacral, it holds the tissues in place. In this case, this is a 3-month post-op. And you see that we actually were able to reduce the pocket by about 3-4 millimeters. Yes, I am doing full pressure. I'm not doing that light pressure as some of you may be thinking right now. But that's a kind of a post-op result that a lot of times we end up seeing, okay? And do we get this type of result every time? Not always, but we do see it quite a number of times. And for being conservative therapy, I think it's a pretty good result. The next slide again is a video of a severe case that I ended up doing. And it was actually earlier in my, adding the Erbium chromium YSGG laser to my practice. But the results were just incredible. I like to go and share that with you. One of the things about the video is that most people say, oh yeah, he's showing me that one case that looks great, and they're not like that. I'm amazed at how this case I'm going to show you, it actually is fairly not predictable, but very common in a lot of these severe cases. So Nathan, next please. So look at the bone loss on that tooth. Pretty severe if I would say. We checked the occlusion. There was a class 3 mobility on the tooth itself, so we had to go ahead and adjust the occlusion. In probing around the tooth, we had 9 millimeters on the facial, 12 millimeters on the lingual of the tooth. Quite irritated. Again, we adjusted the occlusion, take it out of occlusion. In the various steps, like I said, the first step would end up being the deepithelialization. Second step was degranulation of the pocket. In this case, I did minimal reflection because I was afraid that if I reflected the flap, that the tooth would come out with it. So I did very minimal amount of reflection. Most of it was just for the degranulation and clean around the tissue, the granulomous tissue around the tooth, kind of establishing a more ideal biologic health. Again, a little bit of the periacral. The dress was placed for stability since I didn't have any sort of a fixed retention. After 1 week, take a look at the tissues, like a little bit pinker. After 1 month, you can see the fact that the tissues look a little better, a little bit of recession. After 3 months, you can see again the tissues look pretty good. And after 1 year, radiographically, it looks like I may have gotten some bone back. I'm not going to tell you that I did. Here's what it was before. Here's where it is afterwards. Mobility-wise, there's still a little bit of mobility. There's maybe about a minus that was on there. Probing depth-wise and gentle probing, I got about a 3-4 millimeter. I did get recession. I didn't create the recession. The body did it. And so anyway, it actually looked pretty good. I was pretty happy with it. Considering what the options were for that tooth, I was pleased. And actually, the patient wanted to try to keep it, and the patient was pleased also. So I'd like to go ahead and show this case, not because it's the only case that actually came out that nicely, but honestly, it actually is, it's not predictable, but it's pretty common, this type of a situation on an anterior tooth. I really kind of want to emphasize that. Next, please. So here's a couple of befores and afters. The before of the molar, before it's treated, this was purely repair, no bone graft at all. The after, again, you can see the fact that we did get some potential regeneration. I don't know if it is bone or not. I didn't do any histology on it, but sure looks like it to me. And then next slide, please. Pretty good sized defect on that cuspid. Cleaned it out really well. Again, take a look at the post-op. Looks pretty good. Looks pretty healthy to me. So these are some pretty advanced cases that we have that look pretty decent. Next, please. So if you guys get anything out of this right now, I really want to emphasize, if you're into lasers, not into lasers, the laser is not a magic wand. It really isn't. This is all about basic biologic or basic physics and biological principles. You can't deny the fact that what we're doing has to do with biology. My father always says, like Sam said, I started practicing with my father, if it didn't work, I didn't think about the biology. Next, please. Thank you guys very much for including me in this. I really appreciate it. I'm very honored to be part of this this group, and I'm sure we'll have some questions afterwards. So thank you. Back to you, Sam.
Great, Steve. We've got some really good questions, and one of the questions that I think is absolutely critical, and I appreciate someone bringing this up, especially when we look at the whole aspect of methods and materials and studying management of periodontitis. This can either go to Rick or to Don. The question was, is there a difference in the study or in your impressions between the results with an anterior tooth or a posterior tooth? So both of you can chime in, or whomever feels more comfortable.
Well, actually, Rick, probably you may have the numbers in front of you, but we did treat a number of posterior teeth. And in fact, we did treat a number of molar teeth, and mostly interproximal defects, because that's what we were shooting for vertical defects interproximally. But I don't know, Rick, can you pull out those numbers by chance? I don't have it in front of me.
Yeah, I'll find them real quick.
But I do recall you mentioning that the furcation, even those with furcation molars, there was really not a significant difference.
So in each group, in the MIS group, there were 16 teeth with furcations, and in the Erbium group, there were 21 teeth with furcations. And an ANOVA analysis between sites with furcations and those without did not reveal any difference between those groups.
Perfect. Paul, you ever use Imdigame when you're doing these procedures?
Yes, of course. You know, this study is remember we talked about this. This is a study, I questioned why we did not include any biologics in this study. And then you said, there are more studies that's going to follow up with this initial landmark study. So in my private practice, I am using biologics such as Imdigame, GEM21, PDGF. I'm using bone and membranes in addition to using the laser repair protocol.
Excellent. And Steve, directed it just at you. You showed some great defects with some great results. Do you ever go back and do some more just to get it even a better result than what you accomplished the first time?
Wow, great question. I do, but not very often. I kind of come down towards, I call maintainability. In other words, if I, let's say, got about 2/3 of the bone regeneration, and if ultimately it was fairly maintainable, I sometimes would present it, but to the patient as an option. But again, if you feel it's maintainable, if I do not feel it is maintainable, it could be better, then yes, I would go back and do a retreat. And oftentimes we'll see more improvement after doing the retreat.
Excellent. And so, Don, talking about monotherapy versus adjunctive with biologics and osseous grafting, when you're faced with particular procedures, when do you make those decisions to do only laser and to add materials to that?
So in terms of a regenerative approach, we usually limit our regenerative approaches to vertical defects and furcation involvements. If we have horizontal bone loss, there's really no evidence that any type of biologic or regeneration will be significant. I will say that if we have a multiple teeth in an arch or a quadrant that we're indicated or earmarking for regenerative approach, we may use a combination treatment. We will not strictly use a repair protocol. If I have 4 or 5 teeth in a sextant or even an arch, some of the questions that come to me sometimes is, well, can you use a repair protocol for a whole arch or a full quadrant? Well, technically you can, but really in the hands of a periodontal surgeon, it's actually faster to do the entire sextant or the entire arch with a combination with a blade and an Erbium laser. I will say that in our treatment of Peri-Implantitis, we are opting with the Erbium laser approach with mini flaps and regenerative approaches on the implant surface and in the defect. That has been a significant portion of our practice is with peri-implantitis and implant repair. And with the erbium wavelength, we can do two things at the same time. We can remove granulomatous tissue within that peri-implantitis defect more efficiently and more completely than with hand instruments. And we can detoxify the implant surface with one instrument instead of multiple instruments. And so that's how we approach that aspect of regeneration.
Excellent. So Paul, someone asked, can I use a diode laser to do this procedure? And if I can't, why not?
I would refer to my second slide, and then if you come back to my presentation, that those two slides I think explains pretty well. You know, in short, the erbium laser is attracted to what? To water and hydroxyapatite. So it does not heat the tissue, it heats the water vapors. Versus a diode laser is a soft tissue laser. So when you go in, I mean, we're working totally different types of laser. So no, in short, it's not the same.
Yeah, there are two things, and Don brought this up about erbiums. All of you brought this up about erbium lasers. Forget about the brand names for a moment. I mean, for the last decade, whether it be the ADA or others, they always talk about erbium. And to appreciate that, there are two steps in this where the erbium really shines. And that is the removal of the smear layer. And any of you who use anything like aminoelastic protein, you know we use the ETA. And the other is the decortication aspect of it. That just cannot be achieved with a diode laser. Steve, because you and I have chatted about this and you lecture on this, what code would you use for this procedure and why? And the reason I'm saying this, it's a little bit loaded because you kept saying flap.
So as you know, we talk about the codes all have to do with what the AAP, the ADA, the CDT codes are. If you're going to utilize the a mucogingival osseous code, you have to do a few things. Number one, you have to reflect a flap. Number two, you have to gain access to the defect into the bony area. Number three is you have to remove bone around the area. And finally, you have to get some sort of a closure. So the repair protocol, if we look at every step of it, does involve all the above. It involves minimal reflection, it involves an ostectomy, an osteoplasty type of procedure for optimal flap adaptation. So if you really do the procedure, the repair procedure as stated, you can bill for a 4260 quadrant for the full quadrant, 4261. If you do not go ahead and work on the bone, you can only charge for a flap surgery or for flap surgery. And if you don't even reflect a flap, the only thing you can honestly bill for is for root planing, because that's pretty much the only thing that it does. You have to follow what the guidelines are of the ADA, CDT, of really what the codes are all about. So it has nothing to do with the laser or the protocol. It is purely the procedure.
And I know one of you mentioned about the diameter of the tip. It is generally 4 to 5/10 of a millimeter. You do know a periodontal probe is the standard. UNC 12 is 4/10 of a millimeter. Because someone is asking the difference between the tips that we use. Would any of you like to speak to the difference between when we use like a radial firing tip versus an end firing tip?
So in our protocol, of course, in our study, we use the radial firing tip for deepithelialization and removal of granulation tissue, and then we use the end firing tip in terms of decortication in bone. However, there is another tip that's unique to this particular laser that we use for peri-implantitis, and that's a sapphire crystal tip that is a unilateral firing tip, so that we can position this tip so that the lateral firing is only in one direction against the implant surface itself. And we use that primarily for detoxifying and removing contaminants from the implant surface when we're treating peri-implantitis. That's, I believe, a unique tip in the laser industry.
Yeah.
And the other aspect about these tips that I've actually come to appreciate is that they're one-time disposable tips for the most part. And in other types of lasers that we've been introduced to, you're always guessing, well, is this tip good or not, or when do I change the tip? And there's no thought about that. We just put a new tip in every time we use it.
Hey, real quick on that note.
Oh, sorry. Go ahead, Steve.
Oh, real quick on that note, you know, part of the training that we're given guidelines upon the diameters and what's best for certain procedures. But what's fun is that when we talk to people who have been using the laser for a while, sometimes people will use a different type of tip for a procedure that they find actually works for them. So even though we have guidelines, you can actually kind of sometimes interchange some of the tips. But the bottom line is that the guidelines are set to be the ideal for those procedures, but it's not a bad idea to try different tips in different situations.
Rick, this must have come from a periodontist. And so you would be excellent to speak to this. If we were to do the study again, what would you change in the protocol to make it even a better study? And before you respond, please appreciate that this is the 6-month study. The 12-month study will be coming with a complete rendition of the attachment levels that Don spoke about, and this time it will also have a radiographic analysis. So Rick, if the McGuire Institute was to do the study over again, what do you think they would do?
Well, I think first and foremost, the one data point that I would like to see is in tangent with the question about furcations. While we know that there were furcations, we did not actually record the data points as to the grade of the furcation for data analysis. It's recorded in those patient charts. We know what it is, but it's not qualified data, which is important. You have to know that so you can refer that to a statistician for those evaluations. So I would like to report on furcation grades and determine what kind of changes may have occurred in the horizontal and vertical probing depths in that regard.
Yeah. Because as you know, and I enjoy the question when they talk about anterior, posterior, all of us have been down, you know, in our graduate programs and about methods and materials and multi-rooted versus single-rooted. Someone asked again about the 88 codes. If you do this like Stephen John said, and you're seeing bone and you're reflecting a flap, that is a D4260. If you're not doing that, it's probably no, and if you put in D4240, you're still not complying with the description unless you do a flap, and that's just the way life is. Before we close, I just wanted to also suggest to our audience that you're going to have a survey. David's going to come back on and talk about the survey that we need you to complete. But there will be a question, and that question will be, you know, what do you want to know about future, anything about the laser itself? Would you like someone to discuss the laser with you that is local? If you respond to that, put your name down, then I am sure that BioPlace will find you somewhere and communicate. But if you want to know more about the Express laser, the I+ laser, this whole thing about the Erbium chromium, please respond to that particular question with your name. I know we're running out of time, but I just got to have Rick Hurd answer this question, which is, Rick, what do you think are the primary differences between REPAIR Perio and what is considered to be the NAP procedure?
That question has a lot to be broken down. But if we're talking about, you know, from a standpoint of repair and the approach that we have reported on in this study, we're talking about isolated vertical defects, but we're also talking about defects that were treated first with scaling and root planing, and then qualified and still require surgical care via the Erbium laser or the MIST care. While in LANAP, one of the biggest detractors with regards to that protocol, especially in the periodontal world, is they don't employ scaling and root planing first. And so therefore we are unable to determine what is the effect of scaling and root planing by itself prior to any surgical intervention, be it LANAP or what have you. And so that leaves us with some apples to oranges comparison that I think you really can't make along those lines. And if you also look at some of their studies, including their randomized controlled trial by Harris, they did not report on clinical attachment levels. So we have clinical attachment levels as our primary outcome, as Don so eloquently reported on, as being the primary outcome variable that lets you know how well a patient did, because it takes into account recession as well as the probing depth. And therefore, you know if you've gained or lost clinical attachment levels. And in the Harris study and several of their other reported outcomes, they're only reporting probing depths in the LANAP cases. So my primary difference between the two is that, laser is not necessarily the treatment, it's the tool we use. And I think employing sound periodontal practices is what REPAIR employs. In LANAP, while it's a full mouth approach is the way they employ it, doesn't necessarily follow the tenets of average or everyday periodontal care.
Someone also has asked about other hands-on courses for this, and yes, they are. And I'm sure that if you put your contact information on the survey, that they will be more than happy to communicate with you. I want to go to our youngest member because I'm intrigued on how someone who had not been out that long, building a practice, would invest in capital equipment of this nature. So, Paul, you did mention that you have used it less than anyone, but the important thing is that you invested in this. So, just a minute or two of why you did that. What turned you on to do that? What pulled the trigger for you to literally sign a contract and purchase a piece of, fairly significant capital equipment?
Yes. Well, this is all started with Peri-Implantitis. As we all know, we're seeing more and more Peri-Implantitis in our practices. And I'm having trouble trying to figure out how to manage these patients. A lot of times we just watch it, or we say, well, let's go ahead, because we can't really do a scaling root planing. We can't really, how do we go in? We don't want to touch the implant surface. You don't want to probe it. You don't want to use the plastic curette. It doesn't work. So how do I manage these Peri-Implantitis patients? So then I came upon the lasers. Once I start to investigate the lasers, I found that Erbium Laser can significantly, like I mentioned earlier, is the only laser that can treat Peri-Implantitis, that can detoxify the implant surface, can decorticate the bone, promote regeneration, without changing the surface characteristics of implants. Compared to what? Compared to titanium brush, compared to shaving off the implant. So that started me down the path of looking into purchasing a laser, specifically the Erbium Chromium YSGG. And then from there, like I said, it has a slight learning curve. You take the courses, you take the continuing education, then you start to learn there are a lot more procedures in everyday perio office that you can apply laser to. So nowadays, my laser is on every day. Every single surgery I do, doesn't matter if it's extraction, doesn't matter if it is a immediate implant placement, if it is a soft tissue grafting, bone augmentation, periodontal defect, laser is always there. They all follow the general protocol. They're each steps, you can combine them together, or you can take them apart, apply to your specific procedures. So that's why I think Erbium should be in every single peri office. I mean, that is the way to go for us. This is a one piece of equipment that I think is very, very important for every periodontist.
Just to let you know, there will be a continued series of webinars. David can give you the specifics, but Preeti Desai, I believe, will be on in a week. Preeti has a master's in lasers from Aachen. And then following that in October, Paul doesn't know this yet, but Paul will we're going to get Paul back and some others to look at some implantitis kinds of things. So October, we're going to do a little bit of on implantitis. Then we'll have something in November and something in December. By the way, we will also have a study that will be in the International Journal of Peri and Restorative Dentistry in November with Dr. Nevins and David Kim. And that study will be human histology with peri-implantitis plus using biologics. So David, I think we've had a very good evening. Questions have been outstanding. I'm noticing that one of the reasons I didn't stop it at the bewitching hour is because the number of participants, no one was getting off the webinar, which I think is very, very good for all of us. But I really, really want to thank our panelists for taking the time out, and especially want to take time to congratulate all of you for having a very long work day, but still taking the time to listen to what we believe is going to be a new standard of care. So thank you, and David?